We ended last time talking about alpha blockers, and I showed one slide on beta blockers, and it was this slide, which spoke to uh, blockers of beta receptors, specifically beta 2 receptors. And I mentioned that there is one drug that blocks beta 2 receptors, butoxamine, that doesn't have any clinical value, and it's not approved for use. And beta 2 blockers have not been pursued as therapeutic agents, primarily because there are negative consequences that are significant enough when you block beta 2 receptors that really eliminate these drugs from being therapeutically useful. And I'll give you a moment to see if you can figure out what that reason would be. And that was your moment. And it is the fact that you get bronchoconstriction. Bronchoconstriction. Thanks for the horizontal line there. And the bronchoconstriction is a negative consequence. There's few reasons where you would want the bronchioles to constrict. You might think that beta 2 blockers would be useful in causing vasoconstriction because it's the beta 2 receptors that mediate vasodilation. But the bronchoconstriction is too big a hurdle for these drugs to overcome. So, no drugs that are useful under beta 2 receptor blockers. Beta 1 receptor blockers are a different story entirely. And the reason is that beta 1 receptors, as you may recall, are found, their most predominant location in physiology is that they're found on the heart, where when they're activated, they mediate an increase in heart rate, strength of contraction, and conduction velocity. That is positive chronotropic, inotropic, and dromotropic effects. And blocking those receptors will reduce the work of the heart. It will decrease cardiac output. And that originally was found to be useful for having these drugs placed in therapy as antihypertensive agents. And that is that they lower blood pressure because they lower the work that the heart is doing, and it is the heart that drives blood pressure. And for many years they were a first choice drug, but they're not any longer. So just to underscore the clinical importance of this, the number one cause of mortality, that is death, in the United States is due to cardiovascular disorders. And many of those mortalities are associated with long-term increases in blood pressure. And if I can just take a little brief flyer off in that direction, most elevated blood pressure can be referred to as what is known as essential hypertension. And that term has an interesting origin, essential hypertension. And that's what most people have when they're diagnosed as having blood pressure. So why would you call it essential? And that dates back to the 1930s, when the Germans were the first country to figure out how to measure blood pressure easily. And they did so widely across the population of citizens, and they found that a portion of the population had blood pressure that was higher than what was considered normal, and those individuals did not seem to have any ill effects. They felt fine, and so the assumption was that, well, it's just essential for these people to have high blood pressure. And then, of course, over time in longer term studies, it revealed that those people died a lot faster, a lot earlier, than the normal population, and it wasn't hard to put one and one together to come up with the fact that this essential hypertension is actually a predictor of earlier death. So we began looking for ways to treat essential hypertension, and the first two strategic approaches were with the development of drugs that would block beta receptors. Right, and as this is going on, we're discovering that yes, there are these things called beta receptors, and that relates back to the graph that we spent so much time on. That the beta receptors accelerate the heart and increase the work of the heart, and so blocking those receptors reduces the heart work, and that lowers blood pressure, and those became frontline drugs for a long period of time. And the other mechanism that quickly followed that was blocking the alpha receptors, and that was also the physiological effect of alpha receptors was also demonstrated on the previous graph where we looked at the blood pressure tracings, and blocking the alpha receptors will reduce blood pressure as well. And today we know that after long-term use that neither of those approaches produces the best outcome. And as long as I've gotten this far into it, today, as far as I know, the initial treatment for hypertension is to interrupt the angiotensin II system by giving drugs that block angiotensin converting enzyme, or secondarily drugs that block the receptor for angiotensin II. Anyway, that was kind of a long digression, but an important one as well. So, as I said, blocking the beta receptors decreases heart rate, and let me go off on that for just a moment. And this is the point of this is to decrease blood pressure, right? And decreasing the heart rate also decreases blood pressure because it decreases cardiac output. And the heart tries to compensate for that decrease in cardiac output by slightly increasing stroke volume. And that is generally viewed as a good thing because the oxygen demand on the heart for increasing cardiac output via stroke volume is not as great as it is by increasing heart rate. So this actually represents an increase in, I guess, what we would call oxygen efficiency. Oxygen efficiency. Okay. And today, one of the primary places for beta blockers in therapy is in the treatment of congestive heart failure. And I find this interesting because when I took pharmacology many years ago, we were told never, never, never give a beta blocker to a patient with congestive heart failure, because congestive heart failure is a condition in which cardiac output is insufficient, and these are drugs that will reduce cardiac output. So you would think that they would be absolutely the wrong drug, and we would call that contraindicated for congestive heart failure. But longer-term studies show the exact opposite, which is kind of surprising, but beta blockers for patients with congestive heart failure reduce mortality and morbidity. Mortality is death, morbidity is ill effects over the long term, and so they have become an important drug in the treatment of congestive heart failure. There are other uses for beta blockers that sometimes have been used in the treatment of migraine headaches, which are thought to be caused by excessive vasodilation, and beta blockers will reduce that effect. And the pharmacology is complex underlying that. I will say that there are newer drugs that have, some of which have been really quite effective in reducing migraine headaches, and this is not as common as it used to be. And there is a brand new drug that I think has just received approval, and it's a drug related to activation of the calcitonin receptor, of all things, that is effective in treating migraines. And that's will be covered more in a future class. Beta blockers are also used in the treatment of the disease of glaucoma, and I realize that I've mentioned glaucoma several times, and that's because glaucoma is a widespread disease, and it's one of the leading causes of blindness. And the mechanism there is that beta blockers decrease the production of the aqueous humor, the fluid that's inside the eyeball, which lowers intraocular pressure, which is good for patients with glaucoma. And they also stimulate the ciliary muscle in the eye, which accelerates the rate at which the fluid drains from the eye, which again is positively therapeutic in those patients. Beta blockers have been used to reduce the sense of situational stress. I think I made an allusion to this earlier in the class. For example, public speaking is the number one fear of the public. If you survey large numbers of people and you ask them, okay, what do you fear most? The thing that pops out at the top is speaking in public. And you probably are all aware of the anxiety that comes with making a public presentation. If you aren't, you will be before your education is over. And beta blockers have been used to some effect to reduce the sense of anxiety and stress that goes with stressful situations. It's a little dangerous because they cause drowsiness as well. And you don't necessarily want to be overly drowsy when you have to give a public presentation. So it's a matter of finding the right dose. And I thought I would mention as well that beta blockers are useful in treating some of the symptoms of thyrotoxicosis, and this is too much thyroid hormone, because thyroid hormones, part of its physiology is that it increases the number of beta receptors that are expressed on the heart, so it makes the heart way more sensitive to sympathetic stimulation than normally would be the case. And there are individuals that naturally oversecrete thyroid hormone. Famously, back in the, I guess about 1990 or something like that, when George Herbert Walker Bush was president, he started having a wildly irregular heartbeat, and it looked very bad for him for a while. And it was discovered that he had an overactive thyroid gland that had caused an overexpression of beta receptors in his heart, which was causing too much sympathetic stimulation on the heart that manifested in high blood pressure and cardiac arrhythmias as well. And there was some fear briefly that he might die as a result of that. So he would have been treated with beta blockers at that time. And one of the other causes of too much thyroid hormone is that about 5% of the population in the United States has insufficient thyroid hormone and are treated with supplemental thyroid hormone. So as a dispensing pharmacist, you will dispense a lot of thyroid hormone. And that drug is notoriously difficult to regulate in patients. It's hard to get those patients on the right dose. It's easy to overdose and easy to underdose those patients. And an overdosing will result in thyrotoxicosis and can become dangerous because of the effects on the heart and other reasons as well. So there's some downsides with beta blockers, and mostly they are seen because the beta blockers are not specific for beta-1 receptors. They also block beta-2 receptors, and as I mentioned at the beginning of this lecture, that will cause bronchoconstriction. And if the patient has any kind of pulmonary disorder that is obstructive in nature, then that's going to be a bad effect for those patients. They also decrease exercise tolerance, and I talked about that earlier, because they decrease the heart's ability to pump blood And your ability to exercise, anybody's normal person's ability to exercise, is limited by cardiac output. And that may seem an odd fact, but it's true. Your ability to consume oxygen that you need to perform work of any type, be it, playing tennis or splitting logs, um, depends on your heart's ability to provide oxygen to the tissues. And so beta blockers limit cardiac output and as a result limit the amount of work that an individual can do. And I just call that exercise tolerance, right? So exercise tolerance meaning how much work can an individual do. And in an older patient that has other compromises, exercise for them may be a mild to you activity, but it's not to them. They also have some central nervous system effects, is that they can cause a sense of depression and sleepiness and sluggishness and loss of a sense of energy. And again, that's due to the low levels, probably the low levels of oxygen delivery to the tissues, including the brain, as well as some direct effects within the central nervous system. And finally, under these adverse effects is those that are related to energy metabolism. There's going to be a decrease in gluconeogenesis, a decrease in lipolysis, and a decrease in glycogenolysis. And this is somewhat related and important to patients with diabetes. They decrease the patient's awareness of the manifestations of hypoglycemia. So patients with diabetes, when we think about diabetes, we normally think too much blood sugar. Blood sugar is too high. But those patients often suffer episodes of very low blood glucose levels, which causes them to feel faint and weak and nauseous, and their sympathetic nervous system gets set off by this decrease in blood glucose, right? It's the body's natural response to say, hey, your blood glucose is too low. Let's activate the sympathetic nervous system to cause glycogenolysis and gluconeogenesis and get the blood glucose levels back up to normal. Well, part of that sympathetic stimulation is an increase in heart rate, right? And so patients are often aware enough of this change in heart rate to use it as a monitor for what their blood glucose is doing. And so they know that when the heart starts beating harder and faster, that it's related to a low glucose levels, and they can then do something to mitigate that effects. But if the beta receptors are blocked, the heart's not going to respond that way, and so they'll lose their sense of awareness of this hypoglycemia with beta blockers being on board, right? So they'll lose the sense of tachycardia, the anxiety, and the tremor that comes with hypoglycemia. All right, and the compensatory responses to hypoglycemia, like gluconeogenesis and glycogenolysis, are also blocked to some extent by beta blockers. So there's some concern with diabetics taking beta blockers. So other adverse effects include hypotension, blood pressure drops too low, and dizziness is associated with that, and syncope, which is fainting. You may not have heard that word previously. You may have. I think Dr. Alexander introduces that word to you, syncope or fainting. And for patients that are taking beta blockers over a period of time, there is a risk of rebound hypertension, which is associated with myocardial infarction, and that's a heart attack, because a myocardial infarction means that the oxygen delivery to the heart muscle itself has been interrupted or blocked, which causes a heart attack. And that can occur with abrupt withdrawal, and it goes without saying that this is a serious event. And it occurs because of receptor upregulation. So I noted down here with the asterisks that receptors will downregulate with exposure to agonists and upregulate with exposure to antagonists. And that's not true of all receptor populations, but it is true of beta receptor populations. especially those on the heart. So if a patient's been taking a beta blocker for some period of time, the heart will start expressing more beta receptors, but they don't notice because they're taking a drug that blocks the effects of the sympathetic nervous system on those beta receptors. The beta receptors are covered up. But if they suddenly stop taking the drug, then they've got all these unexposed beta receptors on their heart, and a normal amount of sympathetic tone coming down will cause an exaggerated effect because there's so many receptor populations. So patients should be cautioned, don't stop taking this drug once you start or without supervision. So here's a list of 4 beta blockers, and the total list of beta blockers is long, but these 4 drugs represent some of the primary characteristics of beta blockers. The first drug is propranolol. It's considered the prototype for the class. This is the prototype, so this is the one that others are compared to. It's one of the longest used beta blockers. It's not specific for beta 1 or beta 2 receptors, and that makes it not as good a drug as some of those that are more specific for the beta 1 receptors, but it's the one that has the greatest central nervous system effects and the one that's most likely to be used for situational anxiety, for example. And this drug was the drug of choice for the treatment of hypertension for many years. And it is still is in, there still is some use for this. And one year, a couple of years ago, I was teaching this and said, if you're working in a pharmacy and a patient comes in to get a prescription filled for propranolol, which is, I believe the trade name that most of it's sold under is Inderal, or Inderal. I think that's correct. And if they get that prescription filled for their high blood pressure, you can bet that their doctor is at least as old as I am, because that means they, learned their pharmacology of the treatment of hypertension a long time ago, and they haven't updated their knowledge. And that happens, especially in rural environments where doctors are way busier than they should be, simply because there are not enough doctors in rural environments and they don't have the opportunity to keep up. And during the next lecture, a student came up to me and said, "Dr. Rohn, I filled a patient for a prescription for a patient for Inderal for hypertension." And he was working in a rural pharmacy. And I said, "Do you know the physician?" He goes, "Yeah, I know who he is." And I said, "How old is he?" And the student said, "Well, he's at least as old as you are." So, point made. So propranolol, again, just to get back on track, is the prototypic drug in the class, and it blocks both beta 1 and beta 2 receptors. The second drug to look at is a drug called pindolol, and I say next to it ISA, and ISA stands for intrinsic sympathomimetic activity. And this essentially means that the drug, it blocks the beta receptors, but it's also a weak partial agonist, and it has the ability to stimulate the beta receptors a little bit while effectively getting in the way of the more powerful agonist, norepinephrine. So these drugs they are beta blockers, but they're not pure beta blockers, and because they do stimulate the receptor some, but not very much, but enough. Some patients that go on propranolol, we've found out in the past, would have excessively low heart rates. Their heart rates would go down to, let's say, 40 beats per minute. And that wasn't just that was not enough cardiac output for them to be able to get up out of their easy chair. So they were overly, their cardiac output was overly suppressed. But we needed that to treat their blood pressure, Well, then you have a drug, another choice like pendolol, and pendolol blocks the beta receptors, which lowers their blood pressure, but it also stimulates the beta receptors enough to keep the heart rate from going too low. So these patients may get their heart rate down to 65 or so, where it would have been 40 if you just purely block the beta receptors. But you block them with a partial agonist, then you get a little bit of stimulation, but mostly blockade. And we call that effect intrinsic sympathomimetic activity. So ISA is a standard characteristic of beta blockers that you need to know. And then the second one, that is an exception from propranolol, is a drug like metoprolol, which is selective for beta 1 receptors. And the language that we use to describe that is cardioselective. And this is generally considered to be a desirable feature because it leaves the beta 2 receptors alone. And then the next example is the drug labetalol. Right? And labetalol is characterized by the fact that it blocks both beta 1 and alpha 1 receptors. So this is a drug that slows the heart, but it also causes, if you block the alpha 1 receptors, you should be able to anticipate by now that blocking the alpha 1 receptors results in vasodilation. Both of these effects are going to lower blood pressure, and this drug may be effective in the treatment of congestive heart failure as well as another drug that does the same thing, right, which is carvedilol, right, blocks both beta and alpha 1 receptors. All right, so those are the some of the major features of beta blockers, right, whether they're not specific like propranolol and block beta 1 and beta 2, whether or not the drugs have intrinsic sympathomimetic activity, that is, they're partial agonists like pendolol, and whether or not they're cardioselective, that is, specific for beta 1 receptors like metoprolol, we call that cardioselectivity, and whether or not they block alpha and beta receptors together. And labetalol is a representative example of that. And to emphasize the mnemonic for remembering that labetalol does that, it's got an A and a B right next to each other. So alpha and beta, A and B right next to each other. Get it? Yeah, okay, fine. I made the note down here that labetalol, interestingly, has 2 optically active carbons and hence 4 distereomers. So when you take this drug, there's actually 4 drugs in the preparation. And 2 of those drugs are active to block alpha and beta receptors. 2 of those isomers are active to block alpha and beta receptors. And the main effects of blocking the beta receptors are those that we see on the heart, where there's a negative chronotropic and a negative inotropic effect. It's also important that they block gluconeogenesis and glycogenolysis because that's the mechanisms that are invoked by diabetic patients to cause their blood glucose to return to normal after it's been low. Some of them have more or less capability in blocking renin release. And you remember that renin release is at the head of the cascade that results in the generation of angiotensin II. Almost did it. Angiotensin II, right? And this causes, angiotensin II is a major driver of increases in blood pressure. And that they reduce intraocular pressure, right? And that makes these drugs useful in the treatment of glaucoma. Okay. So, as I'm repeating myself here, is just to make sure you guys get these important points about beta blockers, that propranolol is the prototype, but it's not selective for beta 1 or beta 2. That cardioselectivity is an important characteristic of propranolol. The prototype for the cardioselective beta 1 specific beta blocker is metoprolol. Intrinsic sympathomimetic activity is an important consideration. It essentially means partial agonist activity. Pendolol is a representative example of drugs that do that, and this would be used for patients with excessive bradycardic reactions to drugs like propranolol. There is another concept that has used to be important, but some of the clinical faculty tell me that this is not really considered an issue anymore. It's not considered so important, but I wanted you to be aware of it. And that characteristic of beta blockers is whether or not they have what is called MSA, where MSA stands for membrane stabilizing activity. And acebutolol is a beta blocker that shows characteristics of having membrane stabilizing activity, and historically that has meant that it may improve some cardiac arrhythmias, but this is of questionable clinical importance today. And these are examples of several drugs, numerous drugs that exist in the class of beta blockers. But these are the major concepts here: membrane stabilizing activity, partial agonist activity, which we call intrinsic sympathomimetic activity, and cardioselectivity, right, meaning beta 1 specific. Okay, those are points to remember, right? And here's a table that just demonstrates. I took this from the text, and this is just demonstrates the importance of knowing these concepts. And we see the organization of the table is that there are drug names, right? And whether or not they're cardioselective, what does that mean? It means, do they bind just beta 1 receptors, or do they bind more than beta 1 receptors, right? Do they have intrinsic sympathomimetic activity? Either yes. Here's pendolol, the one that I talked about here, yes. And do they have membrane stabilizing activity, right? So either yes or no, right? And see how those will line up. So I'm using this chart just to emphasize these concepts, not to have you memorize the relationships between all these drugs. I'll show you what it is that I want you to know. And then their lipid solubility is going to be a determinant of whether or not they have central nervous system effects. Notice that propranolol is the most lipid soluble drug. And then there's a column related to their half-life. And the only thing that I would point out from this is this drug right here, esmolol. Esmolol has a half-life of 10 minutes. And this is esmolol is actually is a product called Breviblock. Breviblock, and that would be a drug that would be useful if you needed to block beta receptors, but only for a little while, right? So this would be more of an emergency room type drug. So what else do I want you to know about this? Right, here's the big concept, the major concepts that I want you to know, and then some representative examples that pendolol is a drug that has intrinsic sympathomimetic activity. So does labetalol, and so does acebutolol, right? And which ones are cardioselective? Well, these drugs are, the first three do, the A's do, and metoprolol is the one that I think that you'll see most commonly. All right. And that there are two drugs that, whoa, get away. Two drugs that block alpha and beta receptors, and those are here, and you know that because there's got a little superscripted 1 next to the drug. I just wrote over it. So carvedilol and labetalol also block alpha receptors, and that's what I want you to know off of this table right here. All right, and that's the end of the slides. Check this out. Right, I'm going to click on this and see if I can get to this website. Will it let me in? Yeah, it did. So this is kind of like the end of autonomic pharmacology, and I wanted you to show you this. And all over the world, students for generations have learned these drugs by using flashcards, and there's a whole bunch of Google sites out here that have got autonomic drugs as flashcards, and so this is an example of the flashcards. And here's how students study this, and I did this when I took pharmacology. This has been around for a long time. Internet wasn't alive then. We actually used cards, like physical cards, wrote on them with a pencil. So, here's an example: activation of what receptors causes an increase in heart rate and an increased myocardial contractility, right? So you should know that right now. Which receptor is that? It's going to be a beta 1 receptor, right? And I know that, so I'm going to click no over here. And name use of what type of drug will cause bronchodilation. Name one. The type of drug is going to be bronchodilation. We looked at 2 different kinds of drugs that will do that. I bet you this one is looking for a beta 2 agonist. And an example of that would be albuterol is considered one of the most common ones. Let's see. There you go. All right. But so this is a helpful study tool. I thought that might be of use to you. Otherwise, hope you're doing well and have a great weekend.